from 10 different states in India and from 5 different countries. What a pleasure to have all of you together here. I am going to introduce the subject of palliative care. Everybody here already knows about palliative care, but maybe by the end of the session, we will try to bring in some more clarity into what palliative care is. So let me start with a story, true story. Many years back, I was a visitor to an elderly relative in a hospital. He was dying of an advanced incurable disease. He had been in an intensive care unit for the 3 days before this. He had been brought out that morning. In the intensive care unit, his hands and feet were tied, and he was still flailing about and rolling his head, and the family members sitting on either side were keeping him down. So when I was in the room, 2 people came in. The one in front was a middle-aged senior person, obviously. You know how you know, it's not only from age that you identify seniority. You identify seniority and number of degrees also by the attitude you have, the stiffness. As a young student, you go into the college smiling. You come out of the nursing college with lesser smiles. With every degree, you become more and more stiff. And if you are also a director of an institute, you never smile. And there's a weight to your voice. I am the director, kind of thing. Do you think I'm making sense? How many of you smile to your patients? I don't know. You don't have to be stiff and rigid and have a haughty tone to the voice, even if you are very, very senior. God Almighty gave us the power to smile, and what a waste if you do not smile. Why am I saying this? I am titling my talk to you today as when I am a patient. Let me share a PowerPoint presentation with you. I am not talking to you as a doctor. I am talking to you as your future patient. I know that I will need nursing care someday. Everybody does. At some time or other, everybody will need care. And I hope one of you will care for me. And let us start by remembering Dame Cecily Saunders. I don't know how many have heard about Dame Cecily Saunders. Dame Cecily Saunders was a nurse in London. As a nurse, she started looking after people whom everybody else was rejecting. People who were in advanced disease, to whom the doctors would say there is nothing more we can do. She started caring for them. All ladies and gentlemen, please be proud that the founder of the palliative care movement was a nurse. She became a social worker also in between, and then when a senior doctor said, Cecily, go and read medicine. Unless you are a doctor, no doctor will listen to you. So in her 30s, she became a medical student, qualified as a doctor, but she had started palliative care as a nurse. Cecily Saunders died 15 years back, sadly. She died in the hospice that she had founded. So by remembering Cecily Saunders with respect, let us start to discuss what you are going to do to me when I am your patient. You all have various positions. You have degrees. Many have many degrees. And you may hold all these different positions. Shiva, you do all this. teacher, mentor, counselor, manager, researcher, PhD, and director, stiff director. All your degrees and all your publications are of no use to me when I am your patient. Remember that your primary duty and my primary duty is to look after people. Even if you teach them, your students are going to look after them. And therefore, please remember me when you see every patient. Remember my request as a potential patient. You will have your tasks. Doctors always look only at diseases. Nurses look only at tasks. Come in the morning, check the resuscitation equipment, check this, check that, write the morning report, see patients, TPR, vital data, enter them, write the report, etc., etc., etc. They need to be done. But at the same time, when you come to see me, don't look only at my vital signs. See me as a person. I will not be just a case of CA lung. I will not be a case of dementia. You want me to consider me as Rajagopal, a human being with emotions. And if I am scared in that room and I am saying, sister, don't be afraid to hold your hand, even if you have 3 degrees. Or to wipe a tear. Convey to me that you care for me. That will be my biggest consolation. Meaningless things like, don't worry, everything is going to be okay. It's not going to help me. I know everything is not going to be okay. I know you are saying meaningless things when you say, don't worry. But when you hold my hand, I know that you care for me. In the days of Corona, you can't hold hands. You still have your voice. Just say, I am the nurse here. I am going to do the best for you. I am going to look after you. And it will be so very relieving for me to know that there is a human being around, somebody who cares. That's the initial request from me as a potential patient. I will remind you that as defined by the Indian Council of Medical Research, the duty of the healthcare provider, whether it be a physiotherapist or pharmacist or nurse or doctor or volunteer, the duty of the healthcare provider fundamentally is to mitigate suffering, to relieve suffering. There is no exception to this rule. Whatever be the diagnosis, whatever be the stage of illness, your duty and mine is to mitigate suffering, to relieve suffering. And you all know this, don't you? The definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Hey, is that what patients are given in hospitals? Do you just diagnose and treat and take TPR? Or do you look after physical, social, and mental? And though not defined in definition of health, maybe also spiritual suffering? This is healthcare. And if you call yourself a healthcare and not a robot like the patient person I described in the beginning, then this is what we should be aiming at. And therefore, though current healthcare is largely focused on treatment of diseases, not suffering, we have to remember that around the globe, in Ghana, in Malaysia, in India, everywhere, 61 million people are in serious health-related suffering, and in India there are 10 million of them. They need relief from suffering, and that is palliative care. Prevention and treatment of serious health-related suffering, And note the last line. Among yourselves, everybody who has gone through a serious illness in your own family, know that the family suffers as much as the patient, or almost as much as the patient, sometimes more. And therefore, the family is not, member is not somebody to be cleverly pushed out of the hospital as bystander. He is a healthcare recipient. Our duty is primarily to the patient and secondarily to the family. I'll repeat, palliative care is prevention and management of serious health-related suffering of the patient and of the family. Raju, can you put that video on, please?
No, sir, can you stop the share?
Oh, I'm sorry, I forgot. Done. As Raju opens the presentation, let me introduce that the assortment of physical, social, and mental and spiritual issues together form what is called total pain that Cecily Saunders described. Listen to my colleague, Ms. Smriti Rana, who is a psychologist by training, as she was giving a TEDx talk last year in Bengaluru, in St. John's Medical College.
In palliative care, we have this notion of total pain that takes into account the life circumstances of the patient that contribute his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by this stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, this man's hand in his own, and he asked him, he said, "What's your biggest concern, Rao? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own, and this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these 2 children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. Still 6, he said. He was then shown the documents, and he was told, "It is done. Your children will not be fishermen." The transformation on that man's face was magical. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" 1. He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing.
So, I hope I am audible. Raju, am I audible?
Yes, sir, you are.
That was Smriti's description of total pain. I hope Smriti has, I'm sure Smriti has made it very clear, and it's acceptable to you that when somebody is in cancer pain, we will all remember that the cancer may not be the only reason for the pain experience. It may be the social issues, it may be the emotional issues, it may be the spiritual issues. They all come together to give the person suffering. And treating only one thing, looking only at the cancer, looking only at the neuropathic pain, looking only at the vomiting, that's not enough. This management of a person as a whole is palliative care. This is how the World Health Organization defines. What did I tell you earlier? Palliative care is treatment of serious health-related suffering. Here is a detailed definition. Too long. I have put some words in red, but those you have to remember. Palliative care is about quality of life. Smriti described that man near the end of his life. Even there, his quality of life during the last few days were unburdened by the information that his children can still get educated, though he was dying. It is the quality of life of the person, but also the family, including those children. Their suffering also should be our concern, for which we prevent when possible and relieve suffering caused by pain and other physical problems like the vomiting, like the wounds, like the foul smell, everything. And also emotional problems, social issues, and spiritual issues. You may not find it easy to remember the whole definition, this long definition by heart. You don't have to. Personally, I don't. I find it very difficult to memorize more than 3 lines at any point of time. But when you look back on it, this will tell you that what a nurse or a doctor or a pharmacist or a physiotherapist should be aiming for. The depth of suffering can be enormous. We all would have seen it, but we might have walked away from it. This man had cancer lung, which had spread to his bones. And he was in that position for most of 3 weeks. When very tired, he would lie down for a few minutes and he would be back in this position. And all that it took was 5 rupees of medicine, morphine. And the man sat up. He had his first cup of tea in 3 weeks. This is what is possible to millions of people in our country. In our country, we produce morphine. India's morphine is the lowest cost possibly in the world because we grow opium, we make morphine. There are all sorts of fears and apprehensions about it. Because it is it's not known, you fear the unknown. Yes, morphine can cause respiratory depression if you use it stupidly. We give morphine for thousands of patients every month. We don't see a respiratory depression. Yes, it can cause addiction if you use it stupidly. It's easy. It's one of the safest medicines if you understand it. You, the nursing staff by yourselves, will not be able to solve the problem without the doctor's support. And if the doctor doesn't understand palliative care, because 2 generations of doctors in this country have not even seen morphine tablets, they will have all sorts of misconceptions about it. So some education will be necessary. So one horrendous thing that we do is not to treat pain and other physical suffering like that man's. But another cruelty that we do is to dying people. The so-called quality of death index, which ranked the end-of-life care across the world, ranked India among the worst 15 in the country. This is no place to die. Sri Lanka is 2 steps ahead of us. Dear friends from Kenya, you are 4 steps ahead of India in ranking at the end of the world. Malaysia is here, somewhere in the middle, so much better than us. Rajalakshmi, Shiba, we don't have much to be proud about now. This was 2015. Let us hope that there has been some improvement. We have climbed at least a few steps since then. This happens because, for one thing, we don't treat pain and suffering. In India, only 4% of population gets palliative care, pain relief. But also because we give inappropriate end-of-life care to people dying. A friend of mine, a British doctor of Indian origin, says in India, the poor die in misery and neglect, the middle class die in misery of ignorance, and the rich die in misery on ventilators. No one gets a pain-free and dignified death. I don't know how many participants are here present today. Raju, how many do we have?
55 around, sir.
Okay.
And one group is also there.
Yes, so around 60 people. If I forced you to choose between one of these 2 kinds of death, this is obviously a very poor woman dying in her home, a few drops of water going in her throat. This is a middle class or rich man dying in a hospital. Which would you choose? I don't know. We don't have the time to take a vote among the 60 people present. But any day I would choose this. This is inhumane. This is cruel. We'll have another session on end-of-life care. We'll talk about it on another day. Today I'm only giving an overview. Remember, to the people who are close to death, palliative care is vitally important. But not only towards the end of life. Just to explain how your attitude has to change. Some of you must have had dying people in your own homes. Maybe a grandparent, maybe a parent, maybe an uncle or aunt. And maybe you will remember towards the end of life, when the person had no appetite. You can't have an appetite at the end of life. Your body is shutting down. You can't take a normal food. And the nurses and doctors come and teach the family, give him good food, give him high protein food. What the hell? How can the body's cells use the protein when there is no energy level left in the cells? I'm talking about when I'm your patient, remember? Please help me. Don't force food down my throat. Allow me to be a human. Remember your objective. Your objective is not my nutritional status in the day before I die. Your objective is quality of life. Stop force feeding. And we all tend to do that, particularly women, because it's generally women who feed the whole family. Not necessarily, but traditionally, women feed the family. And they have this tendency to, more than men, to say, please have some more. Third hour, please have some more. A little more. 2 spoonful more. To me, as your patient with no appetite, even a spoonful more is agony. Stop this. If medicines may help my appetite, use it. But if I don't like some particular food, don't force it on me. Remember, these may be my last few days on this earth. Let me enjoy something that I like. Maybe just 2 spoonfuls. Why I am saying this is your whole approach to patients has to change. When somebody has no appetite, you must learn to think from that person's point of view. Try to improve the appetite by all means. But if there is no appetite, if the person doesn't want to, you can't force food. You know yourself. When you have had a heavy feast, if somebody comes in and offers you one more meal, can you take it? 3 spoonsful for this man, that for me at that time will be like that. And just giving the philosophy of palliative care, where you concentrate on the well-being of the person. So before, I have 5 more minutes of stuff to share with you, but 8 minutes more. Before I go on to that, if I ask you to speak tell me in one sentence, what is palliative care? What will you tell me? You can chat on the chat box. You all know how to use the chat box? Or somebody can speak up also. What's palliative care? My honored guest from Kuching, Malaysia, want to speak up? What is palliative care?
Hello.
Yes.
Sister Sushila, yes, sister.
Yes, sister.
It is patient-oriented care and improve the quality of life, and it is a team approach.
Okay. Thank you, Sushila ji. But let me ask you one more question. In what kind of diseases?
Sister, can you unmute from your end and speak? We can't hear you. Yes, we can hear you.
It is not only cancer. It is not only for cancer and those who are in the end stage. It should begin from the diagnosis itself, like renal diseases or PCOD or like serious illnesses. It should start from the diagnosis itself, palliative care, and it should be patient-oriented to eliminate the pain and improve the quality of life.
Very good. Excellent. So it is person-oriented, focused on quality of life, team approach. Excellent. For all serious health-related suffering. Not only for cancer, not only for the dying, not only for some diseases. The diagnosis is less important now. What is important is suffering. And let me ask you one more question. So what is, somebody else, will you answer this question? When should it start? At what stage of the illness? Sister Sushila has already answered the question. It should start when the suffering starts. It may be before the diagnosis, it may be at the time of diagnosis. So, okay, you may need surgery, you may need chemotherapy, you may need anything. Let that happen. Concurrently, this should go on. Every nurse and every doctor, every pharmacist, every physiotherapist should also learn the fundamentals of palliative care. They should go hand in hand. That's the ideal. And before I stop, let me also explain to you how we make this happen, at least in our state of Kerala. In healthcare, we talk about the social capital. One of the things that is happening in the society, Sister Sushila, between your childhood and now, or even more time gap between my childhood and now, is that joint families are less and less. Families like this are very common because the man of the house is a migrant laborer somewhere away. Nuclear families and small town hospitals are all closing down with the corporate invasion. Even Christian mission hospitals in so many cities, including in my city, I know of at least 4 which shut down in the last 10 years. All patients go to the corporate places, and there's a huge disconnect or gap between the micro element of the social capital, that's the nuclear family, and the bigger and bigger growing corporate hospitals. The Baptist hospitals in small towns and villages are still such a blessing, I know, but they are also facing competition as we go along. And how we bridge the gap in Kerala is by building in the social capital that's engaging the community. Now, for many of you, this may not be very familiar, but many hospitals go out into the community. We do. And we engage volunteers from the community. And that can improve quality of life beyond what you can imagine. This long row of people on wheelchairs who ordinarily never get out of the house except to go to the hospital, who are shut up in 4 walls, including young men with paraplegia after accidents. They were given the luxury of an evening by the sea on World Palliative Care Day by the volunteers. They physically carried from the home to the vehicle, brought them to the seaside, let them enjoy this. If some of you, at least people from Nagaland who don't get to see that very often, will recognize the attraction that the sea can. But as far as our people are concerned, if they are bound to a wheelchair, the sea is as far away as for my friends from Nagaland. It's very, very far away. And this girl, whom we still see, said she doesn't have normal sensation in her feet, but she said, the waves touching my feet was the best experience that I have had in my whole life. What am I telling you? If you want to really improve quality of life, you and I cannot do it alone. We will have to engage the community. We will have to engage volunteers from the community, and we will have to do it together. But volunteers will come in and help us only if we give them respect. If we are there, if I am there with my 4 degrees and stiff face, unsmiling face, and start saying, hey, you go and do this, they will not come. Even if they come, they will not work their heart unless I treat them with respect. Every one of the 60 of you sitting here, I know, is superior to me in some way. I treat you with respect. And I think every one of them has the responsibility to treat everyone else with respect. And when we do that, we get volunteers to come and help us. And finally, we can't sit in our hospitals and help everybody who needs help. Especially my friends from Chhattisgarh and Assam and Nagaland will bear me out. There are so many people who cannot easily get to hospitals. Care should reach people where they are when they need it, and therefore we take our service to people's homes. We go on home visits to people who are bedbound. We teach families how to care for the patients, and that's how we work. With that, ladies and gentlemen, I'll stop my presentation. I see that it's almost time for the case presentation, but I'll still take a few minutes for questions and answers. Raju, if there are chat questions, please read them out to me. I know that so many of you gave an answer to my question about what palliative care is. I will not read out everything. So it's for each and every suffering. It's care for the terminal case. Sophia, thank you for mentioning that. I'll say that we have to correct it now. Palliative care is not only terminal care. Palliative care is not only terminal care. Palliative care is not only terminal care. If I have the disease and my suffering starts with pain even before the diagnosis, I want your help. It's for all stages of the disease. It is the ajano or ajano, to make the patient die as comfortable as possible. Let me add one word there. To help the patient to live as comfortable as possible till death and then die with dignity. That time between disease and death may be 2 days or it may be 20 years. In the case of paraplegia, it may be half a century. It is to help the patient to live as comfortable as possible and to die as comfortable as possible when the time comes. Journeying together towards the end. I can't pronounce your name. Imliangla? It's a journey together. We may not be able to relieve all comfort. You want to come and say hello to me, the person who wrote that it is journeying together towards the end? Forget your degrees. Turn into a human being. Hold the patient. Walk with the patient emotionally and physically. Walking with the patient. Journeying together to the end. Empathetic care. Empathy, great word. I'm sorry I didn't talk about empathy. Empathy is trying to put ourselves in the patient's shoes and helping them. Whole body care, not only body, also yes, mental and spiritual care. Yes, many other, they are all correct. Treat the patient as a whole with a holistic approach. Yes.
Sir, there is one more comment in between. Adding life to days, not adding days to life, by Anthony.
Anthony, very correct. Yes, it is certainly about adding days to life, life to days. But one doctor, one team from USA did a study on people with non-small cell lung cancer. One group got only chemotherapy. The other other group got chemotherapy and palliative care. And you know something that happened? Actually, people who received both chemotherapy and palliative care lived for an average of 3 months more. So we all used to say that it's about adding life to days, which is quite correct, and not days to life. Well, actually, we may be adding days to life. Well, thank you for that. Any other question before we move on to the case presentation?
Sir, I think we can move on to the case presentation and then come back if anyone has any questions.
Okay, Raju, you are the boss. Hello, Ajana.
Hi everyone, good evening all. I hope all are safe and good. So I'm here to present a patient story. So let's start. So My patient is a 35-year-old male patient and he is diagnosed with traumatic quadriparesis with stage 4 wound over sacral region and gluteal region left side. The presenting complaints are he is on wheelchair since 2006, is having constipations for 3 days, bed sore over sacral region and gluteal region, urinary incontinence present since 1 month, and decreased oral intake for 1 week. History of his illness. Due to his unexpected father's death made him to do the job. So he was working in a construction company in Chennai. So he came for his vacation in 2016. He was only 20 years at that time. So he was helping his mother and he had a fall history. He was carrying around 40 coconuts in a basket and it was very rainy season, and he slipped and all the heavy things was on over his head. And he was immediately taken to next hospital, which was an Ayurveda hospital. From there, he was not having any help. So he went to many hospitals. He underwent surgeries in many hospitals. Then he got admitted from a government hospital and discharged after one month after treatment. In 2017, he had developed UTI and went to a private hospital. From there, he developed a bed sore over the sacral and gluteal region, which was in stage 4. Then he was having a disturbed sleeping pattern and decreased oral intake. So during examination, he was conscious and oriented. His vitals are stable. So his wound site was having warmth and tenderness. Exudate was present. Tunneling was present, and the wound was in irregular shape and foul smelling. And he was having continuous bladder drainage. So treatments and significance of investigation. All the routine investigations were done. Treatment was daily wound dressing with normal saline and a tablet metronidazole powder. Before wound dressing, application of injection silicone over the wound site. Slough cutting was also done. So moving to his psychosocial aspect, 35-year-old unmarried man living with his 65-year-old mother in his own house. He had one brother. He was doing coolie works, but was not very supportive. He is separately living with his wife and 2 children. And some occasion he used to give some money. His main source of income is his disability pension, and his kind friends support him, and some church support was there. He also had taken around rupees 2 lakhs from a private finance bank for the treatment purpose. He used to go to church. Now he is not able to go. This makes him very sad. He is not interested in reading books and newspaper, but he used phone. He was previously doing that. He says his mother like this: I don't think I can walk, so please don't spend money over my treatment. His mother is having back pain since 1 year and also hypertension and is on medication. He is very much attached to his mother and very much respectful. So these are the medication he is getting: tablet tramadol 50 mg, Q8 hourly, tablet amitriptyline 25 mg HS, night 7 p.m, tablet dalcolex 5 mg 2 HS, syrup crimafin 15 ml HS, tablet pantoprazole 14 mg, tablet oxybutyn 5 mg TDS. Main concerns are wound management, physiotherapy, occupational rehabilitation. Summary: 35-year-old traumatic quadriparesis patient with bed sore present over sacral and left gluteal region, that was in stage 4. Had constipation for 3 days and urinary incontinence for around 1 month. Wound cleaning, dressing done with normal saline and metronidazole mixed with Bioline cream. So these are the discussion points. Do we need to provide palliative care for this person? How we address this? I don't think I can walk, so please don't spend money over my treatment. How we can address his spiritual need? What all can be done for this person and his mother?
Thank you, Aina, for the wonderful presentation. Anybody would like to need any more clarification regarding this patient story? Oh. Over to you, sir.
Oh, I thought you were taking it over, Shiva. Shiva or Ayana, if you have anything to say, please continue. I can chip in when I want to.
Okay, sir. Okay, for the first discussion points, do we need to provide palliative care for this person? I think participants here expect answer from the participant side. You can
Three
unmute.
people have said yes.
Okay.
Nancy, Elena, Sophia, Runa, everybody is agreed. James, Sunaina, Sona, all yes, Shiva.
Okay, sir. Then we can move on to the next.
Shiva, let
Sir.
me add because I was talking about this. Here is a person with paraplegia, quadriplegia, right? Aina?
Yes, sir.
Quadriplegia,
Then
Quadriplegia. Okay. Tetraplegia, we call it. So, in a Western country, or possibly, I don't, maybe in a Western country, this person will not need palliative care because there will be a rehabilitation program. He will be enabled to be upon a wheelchair. There will be a support system for him to live as near normal as possible. But in the countries represented here today, whether it's India, Ghana, or Malaysia, or somewhere else, the situation is different. If you learn palliative care from UK or New York and come and do it, this will be one difference that we like to think about. Our people's needs may be different. We do not have effective rehabilitation for all people with paraplegia, and therefore you find people with serious health-related suffering like this. Okay, Shiba, back to you.
Sir. Thank you, sir. So the next points, how we address this. I don't think I can walk. So please don't spend money over my treatment. So I think nurses are spending more time with the patient. We usually go through these questions. So how we address this question? I think you can unmute yourself and talk.
Hello. Yeah, I can speak.
Yes.
Yeah, what I think is when this person says, I don't think I can walk and not to spend money on my treatment, I believe money is not to make him walk, but to improve his quality of life. That is, even if he's bedridden, his quality of life can improve even if he's in the bed. So there will be definite money and finances spent over that. And so that he's able to live a dignified life from all his problems, even if he's at his home. So definitely, we should be countering him or helping him to understand that money is not being spent to make him work, rather to make him more better or make him more comfortable.
Okay. Any other points? So we have a chat. We have to give him psychological and spiritual support to make him understand his situation. We can ask him not to lose hope and give him psychological support. Patient is mentally disturbed, so we can provide psychological support.
Ask that what make you think you can't.
Ask back what make you think you can't walk. These are the points from chat. Can give him hope. So explore what is important to him. We can manage his social, emotional, and spiritual support, also counseling, but expecting his wish. Okay, thank you. Sir?
Hey, shall I do something?
Okay.
Let me be the patient.
Okay.
Let me put myself in the position of the patient. Let me make myself young in my early 20s, having become a tetraplegic at the age of 20. Doctors have to, okay, ask back, what makes you think you can't walk? Doctors have told me that. They have told me that I cannot walk. Patient is mentally distressed, yes, of course. So you are going to give me psychological and spiritual support. Hey, Sunaina, you are asking me not to lose hope. Sunaina ji, what hope can I have? I am going to be a burden to my mother. My brother doesn't care anymore. What do I hope for? Rona also says can give him hope. Absolutely. Without hope, there is no life. But the hope, will you say, no, we are going to start a treatment. We are going to make you walk. Is that what you are going to do? Hope has to be realistic. So I am asking, what hope? Sunaina ji, what hope? I have no hope of doing anything useful. Hope that my mother needs me? Well, because I am here, she is put to such trouble. She has to lift me up. She has a back pain. She can't even lift me up. Nobody else cares. What? Without my mother will be much better. She will be able to go and live with my brother and family. She will have a better life. Somebody, any comments on that you can offer? Shiva,
Yes, sir.
will you stop the screen sharing so that I can see a shown image?
Okay. Okay, sir.
You may have to come back to this later.
Okay, sir.
Okay, I am going to share a screen now with your permission.
Okay, sir.
Let me introduce you to Ashla. She is right now. She is sitting about 20 meters or so away from Sheba and Diana in another room in the same building. She is my executive assistant. She is also
Hello, sir. Hello, sir. Hello, sir. We can't hear you.
Oh,
Now we can, sir.
sorry.
Now we can hear you.
Okay. So you saw the picture. She has quadriplegia, well, tetraplegia. She can't even use her fingers. She types like this using her knuckles. For all her care, she needs help. But she is spending a useful life counseling people, counseling children, counseling people with paralysis, and living a full life as an important member of our team. So what hope could we offer her? We listened to her story. We found out what she is capable of doing. We found her something that she can contribute. Kerala government declared her the youth icon of 216. What am I saying? What the gentleman that Aina, you can put that screen back on.
Yes, sir.
What I am, the story that Aina described, I am not sure what he will be able to do. But something, one, make him feel loved. He says, no one cares except my mother. You convey with your eyes and action that we care for you. We are going to work on your back. I don't know whether we will be able to walk, but even if you cannot walk, we'll help you to live a full life on a wheelchair. We'll find out what you can do. You say you can use your phone. Let us see. Let us see if we can make you a member of a group of paraplegics or quadriplegics so that you can have friends. We will work together. Let us see what we can do. Don't promise anything that we cannot do. Promise only what we can do. But there is always, yes, Sunaina says, hope, give him hope that there is many others with different disability are living their lives as an example. Yes, Sunaina, but not saying there are others also like you. That means we are neglecting his problem. Instead, just comparing with somebody else may not help. But if you are again showing that picture of Harshla and saying, here is somebody, and that itself may not help. But we said then the second point is we look for an achievable target. Right now, you have such and such a problem. We want to make sure that your pressure sore heals. Once that is healed, we'll try to get you out of the house. And at least, okay, not in every country, I don't know, maybe in India, we sometimes are able to do it. Maybe you're able to do in Malaysia. Maybe a motorized wheelchair will make life easier for you. Maybe he can still do something with his hands. And we have people making beautiful flowers. We have people doing various kinds of work, some kind of artwork. We will, am I audible now?
Yes, sir.
Yes, sir.
Yes, sir.
We'll find something that he is able to do actively, and particularly getting him friends on a group of similar people. And you call them 2 days later and ask him, hey, how are you? And even that helps because you are conveying that you care. There are more questions, Shiva, so I'll stop.
Okay, sir.
Sir, I will quickly give what are the things we had done for this patient. So he
Very
was
good.
into a family from 2015 onwards. In 2018, after his bedsore development, we had done flap surgery for him. We had managed his symptoms like constipation and urinary all other urinary symptoms, and we are doing him the medication support and home care. So for his social, his kind friends given him a electrical wheelchair. We took him to our halfway home facility The halfway home facility is one of our facility we provide in our hospital. So in that we have trained him for the ambulation from wheelchair to bed, bed to wheelchair, all this activity. Then his friends take him to the church and so that he can attend the Holy Mass. Then the government also helped him to receive the disability pension. We also helped him for processing that. So this is what we had done for the patient. Now he is actually planning to set up a poultry farm, and under our vocational rehabilitation, the process is ongoing. So these are the things what we had done for the patient.
The third point.
Ayana, let me just give one clarification.
Okay, sir.
When we say we did a flap surgery, we are not saying that in our palliative care unit we do plastic
Oh,
surgery.
no, sir.
What we did was we found a donor to support his treatment. We found a plastic surgeon who was willing to operate on him free. We got a subsidized treatment in a private corporate hospital because the government hospital is always too busy to do this kind of thing. And we facilitated the surgery.
Yes.
But one thing that Ayana mentioned, let me highlight, that teaching him how to get out of the bed to wheelchair by himself. Imagine how many times does the world expand for somebody purely when they are taught to move from the bed by himself. And our patients with the paralysis actually learn to wheel themselves to the kitchen. And in some places, we help them to modify the kitchen so that they can sit on the wheelchair and work. They can make a cup of tea, even cook themselves a meal. And all of a sudden, they are becoming independent up to a point.
Thank you, sir. The third point we already discussed. Ayana shared the points, how we can address his spiritual need. So his friends go out and take him to church, and he make him the spiritual need. So that fourth point, what all can be done for this person and his mother. So we learn many things today. Palliative care is for patient and their family. So we need to care for his mother. So what all can be done for this person and his mother? So Sister Regina.
Yeah, so I think that for the patient and his mother, first of all, I think we should encourage, they need us, and then they have to, we have to be able to encourage them. And then though the patient, we know per the knowledge that we have, the patient may not survive, we should still be able to support them, encourage them, ask them how they feel, know, so that they may not drown in grief and in fear. That's what I think. Yeah. Thank you.
Okay, thank you. Any other points? We can help them to do some small business like handworks, guide them and encourage them to start some works what he can do.
Yes, and I am glad you mentioned that. But ordinarily, Aina, will you stop sharing?
Yeah, sure, sir.
And there are teach online jobs, vocational rehabilitation is helpful. Pensions, yes, Danita Prakash says. See, that government pension scheme is there. But people don't know this. Unless our social workers went and help them to apply, they can't even apply. These need to be facilitated. So, one thing that we have to remember is by engaging the community, by helping the, I mean, when you go out, hey, volunteers come and help, and we give the volunteers respect, make them part of the team. They will do all this because you, the busy nurse, and I, the busy doctor, we cannot do all this by ourselves. Aina and Shiba have to do so many courses a week, and they will not have time. But we engage the community. We just say, put up something on social media. Hey, one of our patients need this, and people offer help. Apply for government jobs, government aid programs. These are all important. But remember, this makes it true healthcare. What we ordinarily do is only disease treatment. All this together will make healthcare truly healthcare.
Thank you, sir.
The time is up, isn't it?
Yes, sir.
One final point, Shiba, with your permission.
Yes, sir.
About the palliative care treatment, relief of suffering for the patient and family, right?
Yes.
And how about the mother's health? Is it our concern?
Yes.
Always, always, always give attention to the caregiver. Andy, do you have any health issues? Have you ever, you are 69, have you ever got your blood sugar checked? Your blood sugar, do you know? And you are carrying a glucometer. Not only the patients, the family members also we should check. And so frequently we find that the caregiver does not look after her own or his own health, and we have another calamity on our hands. Attention to the caregiver is also looking after the health condition of the caregiver. It's an absolute, absolute, absolute must. Thank you all very much, but Shiba has put up something there.
His mother is also, she is a hypertensive patient. We are providing anti-hypertensive medication for his mother. And the last 2 months back, he had a pain, low back pain. So that time we will give the medication. We were giving the medications also. So we were supporting the family, the patient's mother also. So, sir,
I am a full believer in masks. In COVID time, we have to wear the mask all the time. But these, all our friends need to see your face just for a second.
Yes.
Okay. See what smiling faces our people have. Everybody learn to smile. Okay. Thank you, Shiva. Put it on. Put it back on. I want you to be safe.
Thank you, sir. Thank you, sir. Today we have learned many things. Palliative care should start from the point of suffering, and this is the total care, and we can treat it as a person, not as the case. So this is for the patient and their family, and the main aim of palliative care is to improve the quality of life of the patient and their family to excellent symptom control. So when we assess properly, and based on your assessment, you can treat. And then if you treat properly, if you go through the 4 aspects, physical, emotional, spiritual, and the social aspects, definitely the patient's quality of life will improve. Thank you, sir. Thank you for the excellent presentation. Thank you, Aina, for the excellent patient story.
Thank you, Shiva, Raju, Aina. Thank you, everybody. And everybody, I'm glad I had this opportunity to